Hi, everyone. Thank you so much for joining us today for this webinar with Mingle Health. I'm Charles Howes, your host. Our topic is MIPS and the Quality Payment Program, the hardest year yet. We want to dive into the ins and outs of this program and also contextually where we are here after the most acute phase of the COVID pandemic to really help you plug back into the program and understand what to look for this year and what to be working on in your organization to set yourselves up for success, whether you're participating in MIPS or looking at an alternative payment model. A few housekeeping items before we get started here. This session is being recorded. We'll send out the recording by email later this week via the email that you registered with. You can also go ahead and download the slides right now from the handout section, or those will also be attached in the email as well. We want this session to be as interactive and helpful as possible, so please take the opportunity to put in any questions you have throughout the presentation. We've saved plenty of time at the end for your questions, and we'll get to as many as possible. If we can't get to them, we'll do our best to follow up and encourage you to reach out as well, because we seek to help you at every step of the way in this program, so our team would be happy to assist you. By way of introduction to Mingle Health, if you're new here, we seek to be your partner in the transition to value-based healthcare. Since 2012, we've brought together a unique combination of expertise and knowledgeable consultants paired with our technology to guide you every step of the way through these programs to save you time, help you improve outcomes, and ultimately improve your bottom line, which is maximizing those reimbursements, minimizing penalties, and helping you spot opportunities to gain even more financial success in these value-based programs. I am pleased to be joined today by my colleague and founder, Dr. Dan Mingle, Executive Chairman here at Mingle Health. He's a family practice physician, health systems leader, and has really experienced every component of our healthcare system from delivery all the way to measurement, and is the thought leader here behind our work at Mingle Health. He's a nationally recognized quality reporting expert and has lots to share with you today. So welcome, Dan, and thank you for sharing your knowledge with our
Thanks,
audience.
Charles. Delighted to be here and welcome everyone. I'm happy to see you again today on this beautiful spring day. Charles asked me to talk to you today about why and how this is the hardest year yet. So I'll do that, but I couldn't talk about that without also mentioning that it's the easiest it's ever going to be, and I'll talk about that seeming paradox when we get into the slides. It's a small deck today, so I'm expecting there will be plenty of time for questions. So please, as something comes up, don't hesitate to put it in the chat. So with that. We'll of course talk a little bit about COVID as well, since that's a big part of how we got to this particular year's challenges, and then we'll talk about the managing your challenges strategy and success and how we can be of help. So, and I think Charles, you want to do a poll here?
Yes, yeah, to help us shape the presentation and the Q&A, please take a moment to let us know your role at your organization. So those of you just joining us, welcome. The session will be recorded. We'll send out the slides and recording later this week. Go ahead and take a moment, please, to let us know who you are. We've got 2 questions here. What's your role? And then next, we're just going to understand how you're currently participating in the quality payment program. And you can answer that in multiple ways, whatever is most relevant to you and your organization. So just a few more seconds here on the poll. Thank you everyone who's responding. We've got a few clinicians, several practice administrators, office managers, about 32% are part of a quality team, about 25% are consultants and vendors, and 10% are part of the billing function or a revenue cycle management company. So a great mix here. Thank you all for sharing. All right, and then just tell us a little bit about how you are planning to participate this year or have participated in the past. And you can answer all that apply or all that you're kind of thinking about. Um, and thank you so much for kind of giving us that context as well. So we've got almost 10% are, oh, it's climbing a little bit. Folks participating in alternative payment models. A lot of people participating in MIPS, which makes sense. Several people are using their EHR as a core part of that strategy, which is great. And we want to see people leveraging that technology. And many are also using qualified registries or QCDRs. So hopefully if you're using a registry like Mingle, that you're getting value out of looking at your performance and really understanding where your gaps are. And then we've got several folks still in the web interface land. So that's great context. Thank you all. All right. And with that, let's take it away. Over to you, Dan.
Thanks, Charles. So first slide, why is this, or how is this the hardest year yet? And it is a little scary. So this graph follows 6 of the that's 5 of the principal parameters that determine the difficulty of the program. And even there's a couple things here that aren't on the graph, like for instance, all Medicare billing clinicians are now MIPS eligible. As of this performance year, the last of those who were eligible for PQRS and weren't eligible in MIPS are back in the program. A couple of the bonuses are gone. The end electronic reporting bonus ended after the 2021 reporting year for performance year. The high priority measure bonus is gone. Then into the lines on the graph, the range of potential adjustments has been now for the 3rd year. This is the 3rd year it's in its highest possible level. Well, not exactly possible. The Secretary of Health and Human Services has the discretion to push it up a little higher, but I'm not expecting it to go any higher than this, at plus or minus 9% in the adjustment. The exceptional performance threshold, that's the amount that you need to share in the 500 million extra Medicare has put in the pot for the exceptional performers. That the score to achieve that is now at 89, the highest it has ever been, and that is in the last year that the exceptional performance bonus will be distributed, unless of course it changes in the next set of rules. But I'm fully expecting that to go away. The performance threshold, that's the amount that it takes to avoid a penalty. That the performance threshold is up to 75. Again, the highest it has ever been. The data completeness threshold is at 70%. It's been there for a couple of years. It started in MIPS at 50. It cruised in PQRS at 80%. And I'm expecting within the next couple of years they will get that back to its 80% level. Could go a little higher to 90 ultimately. I don't expect it to go to 100%. That's just too high a standard for any data system to achieve. So expect it to rise to the 80 to 90% range. The cost category, of course, we began MIPS with quality being at 60% and cost at 0. And the quality, the weight of quality has been slowly dropping. The weight of cost has been slowly rising. Now they're at their cruising levels at 30% each. And of course, that gets us to the value equation, which is quality divided by cost is the essence of the value calculation. And now the oddity here in the graph, in this range down here, we didn't actually experience the cost category increasing. They've been blanket reduced to 0% for the last couple of years of COVID. So in fact is that we've really been protected from the entire logic of that slow ramp up of the program over the first 5 years. And it's really struck me as I was pulling this graph together. It feels like we've been in MIPS forever, but it has actually been 5 years so far. This is the 6th, and for 3 of those 5 years, we've been subject to blanket COVID exceptions for the hardship. So we really haven't experienced it. Now those numbers set by legislation to come to where they are, they're inescapable. So we've lost that leisure of getting used to the program slowly. And this year we are suddenly in it at nearly full strength. I'll prove the lie to that in one of the next slides. So the million-dollar question, of course, is will there be another automatic hardship exception for COVID? It's almost anybody's guess. I suspect it will not. The chatter is that we finally have to admit that that COVID is no longer pandemic but endemic, that it's always going to be with us at some level. Whether or not it can generate another automatic hardship exception, I think it depends on what the milieu is of variants and rates as we go into the winter, the holidays and so forth. So there could be, but I would not count on it. And of course, that's always the case. Medicare doesn't necessarily care about you as an individual practice. They care when there's enough to sway the political system, but if their policies hurt you, it's not really their concern. So I think we have to be ready for it to hit, to be very hard. And of course, they don't resume at the old position as we exit the hardship. They go right ahead. Now, it will never be easier because it's really projected to continue to get harder. The exceptional performance bonus I mentioned a moment before will end after this year. The 3-point floor on quality performance measures, you may or may not be aware that that's there, but you can't score less than 3 points on a submitted measure if you reach all the requirements of that measure. So by removing that 3-point floor, there will be the full spread from 1 to 100 points for each measure. Data completeness criteria, I expect to increase, as we discussed a moment ago. The web interface ends for MIPS groups after this year. That I think is a hardship. The web interface has been a great way for complex groups with lots of subsystems, elements, multiple EMRs, and so forth to report, to generate some quality statistics. Expect more episode cost measures. We have a handful out there now. I'm expecting that to be one of the major focuses of the program for over the next 10 years, really. Expect the impact of cost during annual adjustment to increase. It's not just that it's up to 30%, but you realize that any change in your scoring, anytime you generate a score, you don't really feel that until 2 years later. There's the performance year, then in the first quarter of the next year, you submit the data, the data's analyzed, your scores are set, and then it affects your payment the following year. So we have not yet experienced a year where cost affected payments from Medicare more than just a little bit. That is in the MIPS program, but much more in the APMs. You've had the pleasure of experiencing that so far. And also, a lot of us are not yet affected by a cost measure. Not everyone is subject to those on the ground, so it will take release of more episode cost measures until more of us are subject to those cost measures. MIPS value pathways is on its way. 2023 is the first year that it will be operational, voluntary with voluntary subgroup reporting and mandatory subgroup reporting starting in 2025. That's going to be a major change, dramatically harder for multi-specialty groups than it is now. Right now, you get away with any group of any size can meet the MIPS requirements with a 6-measure submission. MVPs will reduce that to a 4-measure submission, many of which Medicare will calculate, so you don't have to measure or submit that data. But as a multi-specialty group, when we went to mandatory subgroup reporting, you'll have to report by many, if not all, of your specialty groups. So it could be 10 or more 4-measure sets that you have to submit to Medicare starting in 2025. And then and expect the interoperability and patient access requirements in PI, the promoting interoperability, to increase as we move ahead. And if that's not got you shaking in your shoes, and of course, if you're an APM, it's also never going to be easier than it is now. The web interface ends for the shared savings plans after 2024. Everyone has to use the APP, the APM performance pathway, by 2025. Quality thresholds are scheduled to increase. And they're, in fact, in the midst of this switch to the APM performance pathway, those are increasing. The qualified participant thresholds are in their pre-scheduled increases. Like in MIPS, you're subject as well to the promoting interoperability rules, and expect that interoperability and patient access requirements likewise to increase. And of course, we know, for affecting all of you, Medicare continues to push to evolve and bring everyone into 2-sided risk structures and to full capitation ultimately. And we're seeing for the first time health equity measures or health equity attention in the new program called the ACO REACH program, which is the reformatting of the DCE program, the Direct Contracting Entity program. And hard to know exactly what's going to happen, but I think what we'll see is a few years of experimentation with that, and then it'll be inclined to go mainstream, that everyone will be affected by it somehow. So that's a lot to look forward to, and a lot we're already in for this year. So the challenges you might encounter, I think they number many, and I group them into these 3 general areas. 1, competing priorities, both inside and outside the system, competitive scoring and adjustments, and challenges for systematization. So I'll get into a little more detail on that. First, competing priorities in the program. On the right, I give you the pie chart that shows the current weighting of all the performance categories, and of course, they all demand a little bit of attention, if not a lot of attention. And your challenge is to balance it somewhat, because neglect of anything can result in a total loss of those points, and to really get the best possible score, you need a balanced approach to that. And then, overall, we're facing the whole goal of the program, the aim of this set of interventions, is to try to achieve the triple aims. And I like to use this graphic, 4 aims. On the left, a derivation of the Dartmouth Value Compass, to talk about not only the quality and safety, access and cost that's typical of triple aims, but also practice vitality. That is, it doesn't make any sense to do any of the rest of the work if we build a practice that we don't enjoy working in and can't make a living. So that the practice has to be professionally and financially rewarding to make it all work. And unbalanced attention to those poles creates an unsustainable future for you. If you maximize vitality at the neglect of quality, safety, access, and cost, then you've got nothing in value-based care. If you maximize quality without keeping you accessible and the cost affordable, you really create a great greatly functioning system that no one can afford to use. And it's that we don't need to go into the details there. And recognizing that classic Medicare is only 11% of our healthcare system. Only it's a big slice, but 89% of your patients are in other payment kind of arrangements. So we can't spend all of our time on Medicare programs. You have limited time, you have limited resources, you have patients to care for, there's the business of the office daily to take care of. And as we've discussed, you have conflicting improvement priorities, pulling you multiple ways, and conflicting performance priorities that you have to find that balance on. And scoring is competitive. I said this a few times in my presentations, that the quality payment program has really placed us in competition with one another, even to practices that aren't in your community, that aren't serving the same patient population, because of the nature of the scoring, that it's competitive scoring against one another. Payment goes to those who perform. Preferential payment goes to those who perform the best, so it becomes competitive. And it's worth repeating what you've heard before, that this program is designed to be revenue neutral. So on my graph here, the red area on the left compared to the green area on the right, I know they're much different sizes. We're often used to seeing area under the curve being traditional, being proportional to their weights. That's not the case here because of how the chart works out. But those practices that fall into the red below this point here is the performance threshold. So you know that anyone below is getting a negative adjustment, everyone above is getting a positive adjustment. The amount of money that is collected here in the negative side is distributed to those here in the positive side. It's exactly the same amount. Now this area here, that's the exceptional performance bonus, and as we said, that's going to go away after this year, and this line in graphs in coming years will just go straight up, and then the program will be budget neutral. And that's an issue because so far almost everyone has a score. I think 85% of people in this last year, 85% of practices providers were in the exceptional performance range. So there really wasn't much negative adjustment to pay off everyone else. Now cost is going to perform much differently than quality. Quality, you work on benchmarks that were generated 2 years ago. So this 2022 year is scored against the performance of 2020. And you know when you submit your data in the first quarter of next year exactly what your quality score is going to be. It doesn't vary from that. Cost works much differently. Cost is truly judged on the curve. You don't know what you don't have as much visibility to the costs as you do to quality. Medicare calculates that entirely from claims. So your score is invisible until they do the calculations after the claims run out period. And then they can't, they don't even score that until they compare the data and then can line everyone up by percentile. And the top performing practice in the country, that is the lowest cost, it will get full score. And the lowest performing practices in the country will get a 0 score. And you don't know where you fall on that range until it's all done. So it's a we're going to find in coming years that we're going to see a lot more practices falling into the below the performance threshold range, therefore more negative adjustments that are funding more positive adjustments. So there's going to be a great spread coming as we get deeper into the program. So path to success, is different for every practice. And it requires a fair amount of work. One, to increase your situational awareness. The rules do change every year, and Medicare also has an inclination to change their interpretation of their own rules in mid-season. So now this is our entire business, so we're watching that steadily, and can typically know when we see a change in the rules, a change in the interpretation, we can quickly look at our data and figure out who's affected and change submissions really on a dime to resubmit and correct those errors. So and they're not easy to watch. They can be quite subtle. The rules every year, last year's final rule was in a document 2,400 pages long. You need some help as well as just to keep aware of those. Measure specifications, you might be doing great in a measure, and the specifications can change. Now, it's typically with plenty of notice, although there's a couple ways they change last minute. So watching those is important. Watching the benchmarks, because that scoring based on the relative score based on your performance can change year to year. So the same performance this year scores one way may score much more poorly next year. So there's lots of things to be aware of. Every practice is a little different. You have different strengths, different weaknesses. Your patients have different needs, different capabilities. So weighting your efforts at one versus another of the performance categories is really a unique challenge for you that we pride ourselves in giving a great deal of guidance and help with. You want to be systematizing. That is, I discourage people from jury rigging a way of dealing with a measure year by year. Again, those measures change, and if you have one way to do hemoglobin A1Cs, it's not going to work for blood pressures or immunizations or whatever care you do and whatever's being measured. Then as you need to change measures, you really have to reinvent the whole system. Whereas we realize that that patients have characteristics that put them into the denominator. And we should be tracking those whatever they are, those characteristics that can be recovered in a simple query. And then the possible interventions, the things that we want to do for our patients under certain circumstances, they're also tracked in the EHR as discrete data that indicates whether they're on that medication or their blood pressure is this or their hemoglobin was measured at that, or whatever is we're measuring, those numerators have to be available in the data. And we want to be able to spin that on a dime. And it's not for our practices to be high value. There aren't 6 measures or 4 measures under the APP or 10 measures under the web interface. There aren't that small number of measures that indicate we're doing everything we need to do. I've been speaking with one of the medical evidence vendors who a good friend who gives me some very interesting data. They're monitoring the medical evidence every day and publishing what you need to know about with a gradation of the level of evidence that's out there. And they divide medical evidence into more than 30,000 rules. If this, then this should happen, or these are your choices. Varying levels of confidence, but again, when we really want our system to be flying, we need a system that we can spin to measure any of those things. Just think about systemization. Think about how you collect data, how you store data, how you can recover data, to be watching things. You can measure anything that you want. You don't want it just to be suitable for hemoglobin A1Cs, just to be suitable for blood pressures, whatever. We want to keep it simple. That is, we don't want a different system for each. We want simplification. We want standardization, and we want integration. And in this word, I'm not using the word integration in the technical sense of making the data readable by everyone, although that's valuable. I'm talking about integrating our systems of care, integrating our logic, that we can't. If I, as a primary care physician, seeing a patient in the office that needs a specialty referral, we should be integrating that approach to the patient and that approach to the problem. When I'm seeing a patient with hip trouble that needs evaluation, and needs a diagnosis, and ultimately may need surgery, I want that path to be logical. I want it to be efficient. I want it to work well and be predictable. So that's what I'm saying about integration. So always think, I recommend these three words always be, I don't have exactly 3 words there, but you'll see them in another slide: standardization, simplification, and integration. And I guess systemization is the synonym I'm using in this slide for standardization. So again, I've talked about that system of quality measures that's extensible and scalable, that changes with the emerging medical evidence. We've got to change. Our system has performed in the past up until now with an average of 17 years to take new evidence and get it into routine practice. And that's just not good enough for the value care that we all want to provide. So we want the measurement system we're building now can deliver that if we bring it back in to our at the point of care to help guide our choices as we're seeing patients day to day. We want a system that controls cost. Now we're just starting to get into the cost performance measurement with MIPS, and we should be keeping this in mind. What are the ways that we will use? What are the methods we'll use to control costs? And they're similar. That same standardization, simplification, and integration will also help to control costs. We want to think about what is the optimum frequency and how to see patients, frequency and venue. Is the best frequency a monthly visit, a quarterly visit, and for what? How long do they see the specialist when there's a referral? When do they come back to primary care? Those are things that go into cost. What is the sequence of events that gets them from the initial complaint through the system? Again, keeping up with emerging medical evidence. And we want, I think, the frontier beyond this. We first worked on quality, that now we're embedded in cost. To really control all of this takes a patient management system. So we'll be thinking next, this is where we'll be putting a lot more work in years to come in those systems to engage and manage patients and facilitate self-care. And we want it to be reliable, we want it to be scalable, we want it to be comprehensive. We particularly want to watch patients through transitions, be able to track them as they move from one practice to another, from in and out of hospitals or other institutions. Make sure they weren't lost in that shuffle. And we needed documentation and analytics system that supports it all. The document is between you and your EHR and your patient. The analytics systems should be people like us and your EHR and you and your patients to work that out. But that's got to underlie everything and make it all come together effectively. So what can you do today? That's given you a lot to think about. Not all of which is urgent today. But as you think about your building your practice of the future, you need to be aligning your improvement processes to the programs that you have to be working in, like MIPS. So it pays to align those things, do those things first that are required, that are going to affect your income most quickly. You want to be analyzing your data on a regular cadence. Quality reporting should not be an annual exercise of pulling the data together and submitting to Medicare, but you should be looking at it early and often. You should be at least quarterly, maybe monthly, maybe even as often as weekly. You should be examining your data, understanding how you can improve it, and working on those progresses. So year by year, you see improvement in those systems, in those scores. You need to understand and watch the changes to those requirements impacting you, and look ahead to the trends. And Mingle wants to be there with you. We've built this. I left the practice that I loved to be here to help you with your journey through this toward value-based care. So I'd love to be able to help you. We'll help you work with your strengths and weaknesses, set rational goals. Does it make sense to shoot for the highest available bonus? Is penalty avoidance the best you can hope for, or even the least penalty what you can gain? We're here to get data from whatever system you have, knowing that all systems are flawed. They all have their difficulties, but we've made a business out of meeting you where you are and getting data from whatever system or systems you use. And again, find balance in your approach, your particular approach to improvement and value building. And I think, that looks like, we made our mark in the merit-based incentive payment system. That's been our introduction to you and the market. And we're moving, particularly with the APP coming, we're moving heavily into the Medicare Shared Savings Program. We are working in primary care primary care first. We are working on the equity directed stratification of your measures for ACO REACH. It's not just quality measurement reporting. With primary care first, we're working in patient attribution, HCC risk score optimization. Some of the earliest, we're working on a comprehensive set of cost measures to bring to you. And I'd be delighted to hear from you what we could release early that would help you the most. And from those claims analyses, HCC risk score optimization, leakage analysis are some of the big things that can help. We've been using our check product to help people with care management. and with attribution services, and we look forward to seeing that more widely distributed and used and improved with use. And I think our conversations in coming years are going to be centered a lot more around cost containment strategies than they have in the past, and of course needing to continue attention to quality. So I think at that point, Charles, you said you had another
Yes.
poll.
Thank you so much for that, sharing all your knowledge with us, Dr. Mingle. We have a quick poll that is a little MIPS oriented, but feel free to interpret it broadly based on your particular context. We'd like to know what challenges you're anticipating that you've arrived to this session today with, and this over the last 40 minutes here have emerged for you. Select all that apply, but we're just curious what you anticipate being the most challenging for you and your organization or the organizations you support. We'll give that about 10 or 20 more seconds. And then we have gotten to the point, we've got plenty of time here for questions, and we've got several that have come in already, so thank you so much for those. Please do take a moment to share any questions, feedback, suggestions that you have, because we are all ears and would like to go ahead and have the interactive part of our conversation here. All right, well, thank you, everyone. So I'll just share this back to all of us so we can take a look. It looks like some of the biggest concern is that performance threshold, so that's understandable. Engaging clinicians is most of them are right up here. What's interesting is that many of you are feeling that COVID-19 is less of a challenge that you anticipate. And it's hard for us to know. Feel free to put in the chat if that means that you understand the challenge and you're navigating it, or if that's really having less of an impact on your organization at this moment. All right, so let's go ahead and dive into some of the questions here. Our first, if you want to do, let's see, let me pull it up. All right, so our first question is a great one from Carol. For practices that are FQHC-like with heavier Medicaid or self-pay patients than Medicare Part B, and high HCCs with expensive care, for example, specialists, emergency hospital, providers who are all opt-in eligible, is there any benefit to risking opt-in with 30% cost in 2022?
Good question, Carol. I would think that the danger is not knowing where you fall. And there's a lot of moving parts there. You may have very complex patients that are expensive to take care of, but it's not always straightforward to know whether you're coding those entirely accurately to be judged fairly by the HCC scoring. My experience is everybody underscores their HCCs or undercodes their patients to get the right HCC score. And every time I see pushback, I tend to see people correct it enough to correct their income, but not to necessarily correct the scores. So, and you get very little visibility on your performance until you're past the year. So I think there is danger to opting in if you don't have to, until you see at least 1 year under your belt of how you perform in the cost category. Now you can look back. Medicare has given cost input in the past. I noticed that they did not give input during these last 2 COVID years. But theoretically, your performance should be more similar to the pre-COVID years when you might find some guidance. in your feedback reports. So yeah, if you look back and you've always performed fairly well, I would consider opting in. But if you don't know, if you can't find it, think that there's lots of reasons you're different now than before we went through the COVID years, then I would take I would wait. Michael asks, any information or insight into whether benchmarks will be established for popular measures that have been changed and therefore no longer have benchmarks, like tobacco cessation, counseling, use of high-risk meds? Yeah, Medicare's methodology there is fairly straightforward and no, not necessarily predictable. The intention is when the measure for new measures or measures that have newly changed specifications, they wait through until there's enough data generated to give benchmarks. Now, if that's in the first year, they will score you on it on the benchmarks generated that year. So use it. Use one of those measures at your peril when they're new. Not knowing where the scores are going to be. I would be a little more inclined to submit those as extra measures that is beyond the required 6, so that you could gain from it if you happen to fall well on the newly generated benchmarks, or you don't. It will be Medicare will give you the score from your 6 best performing measures. So extra is probably a great way to use those. Lori asks, is there any technology or even lists to capture the top HCC risks? Yes, technology certainly, and that's one of the things we're working on hard, and we're already delivering some data on that. We've got a more comprehensive data set coming. I used to be able to find Medicare lists of those HCC coding, and have written those algorithms in the past. Now they deliver it as a prepackaged set of routines, so it's hard for a person to dig into that to understand the details. It's easier to understand the principles there. I think they're described fairly well in certain places, but to actually map the codes, well, when they were available to the reading public, they still weren't that easy to sort through. But anyway, look for technology. Many of EHRs I notice are now telling you when a diagnosis is on the HCC list. It's often embedded in the selection panels. And certainly there are many analytics firms like us that can look at your data set and tell you what's there and what's not. And I like a couple of basic HCC analyses. One is what has been diagnosed on a patient in the past that was on the HCC list. It hasn't been diagnosed this year. And that by diagnosed, it means being put onto a claim form and sent in. You only get credit for the complexity when you build, when it's been on a billing form. Being on the problem list isn't enough, although being on the problem list is important. What I found is when the HCC compliant code, we won't say proper or improper, when the HCC compliant code is on the problem list, it's highly likely to be in a claim form. If it's not on the problem list, it's not likely. So one of the best things you can do is to, with the guidance of a technology vendor such as us, go through that list and make sure that if the patient does have that problem, that it ends up on a claim. And that's a great reason for the annual wellness visit. to make sure you're hitting all those things and getting them all on a claims form at least once. The second I like is near misses. That is, that takes a lot more coding and a lot more sophistication. But to look at there's some that are obvious. If you see a code meaning diabetes and a code meaning renal failure, they score better in HCC if you're diagnosing diabetic renal failure. So they don't score as high if they're separate. So a few things. See, without another question being sent to me,
We've
there's
gotten
some.
through we've gotten through a good chunk of the live questions. So let's go ahead and jump into a few that were submitted in advance.
Yeah, it's great. I love this. I love all the questions. It's lots of fun to handle them. But there's a particular value to the pre-submitted questions because I get to think about them a bit more and even bring in some other graphics for that. But Marilyn asks a great question. How do we deal with the focus on costs even though we haven't received cost data in a few years from CMS? And that is a shame. In the past, CMS has been giving us data about cost. If they are measuring it all, they typically gave us some feedback on it, even if we weren't being scored on it. And they haven't done that. Well, there was 1 year they haven't done it. 2019, there were cost measures, and we did get cost feedback in the reports. 2020. They zeroed out the cost category, and in the feedback reports they just didn't give us any feedback. 2021 isn't out yet, and of course we're in the 2022 year, so we don't. If 2020 is an indication, we won't get cost feedback in a couple when the feedback reports come out in a couple of months. So what can you do to focus on cost? Well, here's my standardize, simplify, and integrate. There's some generic things you can do that just we know save cost. And one of the biggest threats to cost is that we're inclined to custom make every person's health care. Someone comes in front of us and we remember everything we can. We do everything they ask for, and there's some things that are missed because of attention to other things. So as we systematize, standardize our approach to patients, we can be improving on the costs. We also, patient management, I think, is key. So as you build those systems, particularly managing patients through their chronic illnesses, through their life stages where different preventative interventions are or monitoring is indicated, managing their transitions in and out of the hospital and other organizations or across the different specialties. Those are classic places where patients are lost and costs accumulate. Planning care, careful selection of referral providers. Now, we don't have a lot of data on them yet, but that's available if you from certain places, certain vendors. Again, that's that data set we're working on bringing live that will follow patients with particular diagnoses and problems across their referral sources and start to give you feedback on where they get the most cost-effective care. So, and the data you'll be looking for over the next couple of years, my quick list on that is in that right-hand column. So a lot you can do generically, engage a vendor with some, like us, with some cost analytics to share. Let us know as we're bringing this bigger set live, and it may take some time, what can we release early that would help you more. Let's see, I've got another submitted question, currently live submitted question from Maxine, who says, when selecting MDM of E&M coding, medical decision making, is the problem addressed? Do we enter the other complex diseases on our claim that can increase the HCC total, even though we haven't truly addressed them in the encounter? Yeah, I think that great question, Maxine. And I think this is particularly one reason why the annual wellness visit is of value, that you're you're looking at everything and judging its level of control and how what you need to do. It may only take a moment of attention for each of them, but it does. I think it's easy to justify those codes being on your AWV uh, claim. But in the normal course of events, even if it wasn't a big factor, you're typically taking all of um, the whole context uh, into account as you make decisions. So you may think very little of it. It's so quickly there, but knowing the patient's diabetic, knowing they have hypertension, knowing that they've got diminished renal function, knowing they're on this medication, those are things you take into account, and it doesn't have to be a lengthy process to deserve being on the claim. So I think most of the time it's easy to justify having an existing disease on the claim for nearly every encounter. But there's obviously gradations, and I think the closer the reason for the visit was to really requiring knowledge of that, the easier it is to justify. But I think the great thing about the new coding guidelines is there is less reliance on that the history and the physical. There's no reliance. There's no code justification that relates to the history and physical elements. It's all medical decision making. I think that makes it a lot easier for us. Thanks, Maxine. So the next pre-submitted question on reweighting. Can large groups reweight all to PI? And yeah, Jeanette, great question. And the answer is no. And I think it's good. Here's the reweighting chart, or one of the couple of reweighting charts that Medicare published in this most recent final rule. And as we look at all, this covers every reweighting circumstance. And you'll notice under promoting interoperability, there's no situation where you get to 100% in PI. In fact, what you also notice on the left side here is that there are only 3 general scenarios, those that are just fully in, no reweighting necessary, 1 performance category reweighted, or 2 reweighted. There isn't a 3. If you get to the point where you need 3 performance categories reweighted, they just reweight the whole system for you, the whole thing, and you get a total score that's at the performance threshold. So simple. I made it a little more complex than it needed to be, perhaps. You can't reweight to all PI. Dwayne asks, we'll be submitting directly from our EMR this year instead of via CMS web interface, which means all payers will be counted, yes, not just Medicare Part B. Do you have recommendations for ensuring the best possible performance? Well, sure, Dwayne. Great question. Here again, simplify, standardize, and integrate are the rules to keep in mind, and you want to do that with your EMR reporting, your quality management efforts as well. And also, I would say on the right-hand side, measure early, measure often. We talked earlier about doing it quarterly at least, monthly possibly, weekly possibly, but you want to measure and you want to start to understand the deficiencies in your measures. And it's not just a deficiency of quality that will give you poor scores. It's really some of the earliest things you'll find is deficiencies of documentation, deficiencies of your measurement system that you need to correct. And it's time consuming, it takes some effort. And getting started, I would urge everyone who's who's leaving the web interface to not wait till the last minute. Now, for MIPS groups using the web interface, this year is your last minute. So you either move on now or you move on next year. I'd suggest you move on now, because you've and maybe even plan a dual submission, do a web interface submission and an EHR or CQM submission instead, or as well, so that you can, comparatively, the web interface is easy. It's based on, most people base it on a chart abstraction. In fact, we really found that trying to do it electronically was more difficult than doing it by chart abstraction, with all the, well, we don't need to go into the details. You don't need to feel my pain. You're feeling enough of your own. So the interesting thing about web interface reporting is that you abstract the charts, and any good abstractor can find data anywhere it exists in the chart, or nearly so. And it's no mystery that web interface scoring has always tended to be the highest of the available methods. In contrast, the electronic methods, and both CQM is highly electronic, as well as EQM is wholly electronic. You can fail in collecting the data, you can fail in entering the data, you can fail in entering the data in the right place, and you can fail in putting it in exactly the right place, but the right place not working right. So it doesn't really populate the data set as you expect it should be. So you really need to chase down all of these problems. So I suggest measure early, measure often, audit specific patients. We've been in the habit of giving clients a list of their patients who are performance met, a list of their patients who are performance not met. It doesn't need to be comprehensive. In fact, if you take 10 of these and chase them down for each category, you will get some great guidance as to where the failures are. And every time you do this, you'll find more, and you'll chase more of them down. And you'll find templates that malfunction, that don't put the data where you expect it to go. You'll find that your providers are finding interesting ways to report that, to document that don't really work that well. And I notice I've gotten past the top of the hour.
It's a great moment to end on. Measure early, measure often. We're here to help all of you who are ready to jump in and look at your year-to-date data. I put in the chat, we'd love to offer a free consultation, no commitments, no contracts, but a free consultation to anyone who wants to talk through a strategy that's best for your organization. You can reach out at hello@minglehealth.com, or jump on our website and also just reply to the email you get with the slides and the recording. So Dr. Mingle, thank you so much for sharing all your wisdom with us today. If we didn't answer your question, reach out to us. We're here to help guide you through this program and any value-based program you're looking at. So please do reach out, and we'd love to work with you. Thank you all, and have a great day.
Thanks, everyone. Ta-ta.